Thanks for joining. We'll get started in just a couple minutes. So good evening, everybody, and welcome to the Center for Hope and Healing inside the Cancer Survivors Park. We're going to continue our monthly series of cancer prevention and wellness. I'm Dr. Jeff Jaguar, and I'm your host for this series. I always say that it's always sunny at the Cancer Survivors Park. I don't know that it is now since Eastern Daylight Savings Time, but hopefully technology is going to bring us to you in your warm and dry house. So our guest speaker, we're very pleased to have Lindsay Metcalf tonight, who is a certified genetic counselor, and she's going to give us important information about a burgeoning field, which is genetics and cancer. So Lindsay, thanks so much for being here tonight, and we'll have a little bit of a conversation. The other thing is there is a chat box, and if you have any questions that you want to ask Lindsay, even during her talk or afterwards, feel free to do so. We'll monitor that. Lindsay?
Thank you, Dr. Jaguar. It is certainly a pleasure to be here at the Center for Hope and Healing. I know you can't see it, but there's a fairly nice sunset happening after quite a rainy day. So that's always a good thing to see at the end of the day. Yeah, I'm happy to be here talking about something that is a passion of mine as a genetic counselor. I have been a genetic counselor for 17 years now, and it's been quite an interesting field to work in, and I'm happy to bring you guys some information, hopefully answer some questions that you may have. And so without further ado, let's get started. And, you know, it is very appropriate that we have this topic during the month of November, because the month of November is Family History Awareness Month. It seems like everything gets its own day or month now, but it is a good time because Thanksgiving is when we usually gather. This year it's probably going to look different for a lot of us, but we usually gather, and so it's a good reminder when you're with your family to bring up this topic of hey, what kind of health concerns have we had in our family? Is there cancer? Who's had cancer? You know, so just take this opportunity this month as you gather, however that looks, and that's always a good thing to get the information. So tonight we're going to talk about a lot of stuff. We're going to try to cover a lot of ground, so I might be moving kind of fast, but please ask questions as we go along. We're going to talk about what is hereditary cancer, how is it different than non-hereditary cancer, what do we do if we find someone has a hereditary cancer risk, how do we manage that, what is genetic counseling all about, what is genetic testing, what are the ins and outs of that, and also we'll touch a little bit at the end about the direct to consumer genetic testing and what it can and can't tell us. So sometimes it's helpful to start out with something that genetic counseling is not. So no, I'm not talking to genes and trying to convince them to behave, although certainly that would be great if I could. But you know, it is a little different than that, as we'll see as we go along. So we'll come back to this slide a couple times because it's kind of a home base. So it's a good old pie chart here. And normally when you look at these, your eye goes to the piece of the pie over here, this big yellow piece that's the biggest. And you'll see, okay, if we're talking about cancer, most cancer is sporadic, meaning it happens by chance or perhaps due to something in the environment. It's the background chance that any of us could have a cancer, sporadic cancer. Now, the smallest piece of the pie is what we will talk about the most tonight and what we focus on in our genetic counseling clinic. This 5 to 10% of cancer that is truly hereditary. So those are the families that have a particular gene that we can track that is associated with a significantly increased cancer risk. And then this third section is familial. And you might be wondering, well, how is that different than hereditary? Well, it's a different category because those are families that perhaps test negative for some of our genes that we know about, but still there's more cancer than you might expect, possibly because of a shared environment. You know, you usually spend several years at a time living with your family members, and so you share an environment that could increase a risk there. So.
Now go back to that slide, Lindsay.
Yeah.
So in 17 years, fair to say you've had to keep up with things because they change daily.
Yes.
But that purple piece of the pie in your 17 years has gotten bigger. And would it be fair to say that in the next few years that the red piece of the pie some of that will become purple as we find new genes?
I think yes, you're right. It should. Years ago, when we first started figuring out what genes were responsible for hereditary cancer, our technology is not what it is today. And so we have uncovered numerous genes now that increase risk for cancer. So if someone had genetic testing, say 10, 15 years ago, in all likelihood, it was 2 specific genes that we knew about. Now we routinely test for over 80 different genes. So yeah, we're moving in a good direction for sure. So like I mentioned, sporadic cancer is what happens most of the time. So don't let the fact that we're spending all our time tonight talking about hereditary cancer make you think that all cancer is hereditary, because it's not. So, you know, the biggest risk factors for anybody to have cancer are these 4 prongs. You've got things in the environment, some of which we don't understand. You've got lifestyle, which is diet, exercise, genetic factors, which is what we're talking about tonight, and then aging, which is something that happens to the best of us. So here's our reminder. We're talking about 5 to 10% of cancer that's hereditary. So let's dig deeper into that. All right. Back to Biology 101. You probably remember, hopefully, that our bodies are made up of cells. We've got heart cells, colon cells, brain cells, skin cells. Inside all of our cells, we have our DNA, and it is packaged in these big packages called chromosomes. And then when you zoom in on chromosomes, you see this double helix that you may have seen in your biology book. A gene is simply a piece of DNA with a specific job to do. We have over 20,000 different genes. We don't yet understand all of them, but like Dr. Jagir just mentioned, our knowledge of which genes increase your risk of cancer is increasing, thankfully. So a gene is basically a piece of DNA with a specific job to do. Now this slide, we're going to
Oh boy.
We're going to go a little bit slower here.
Well, yeah, no, hopefully we're not going to be tested on this.
Well, no, thank goodness. That's what I'm here for. You don't have to take the test because I took all the tests.
Thank you.
Now, we're going to go slow here, but this is kind of the crux of what hereditary cancer is versus non-hereditary cancer. All right, so if you could see my mouse here, we're starting over here on the top left where we're under the non-hereditary cancer top part of the slide here. So a key thing to remember is that everybody gets 2 copies of each gene. And so if this is 2 copies of a gene from dad, the other 2 copies of a gene from mom, mom and dad each give us 1 copy of every gene. So here's potentially you. Most people are born with these cancer fighting genes that we're going to talk about working just fine. Most people don't inherit mutations from their parents in these genes. What happens as we live our lives is this next part here, where we are all susceptible to having mutations that just pop up in our DNA because we're human. So if we get a mutation in one gene, usually it's no big deal. The other one's working and it's making up for it. But if we live a little bit longer and we have another mutation show up in the other gene, then there's no good copies of that particular gene. And if that particular gene's job was to protect against cancer, then cancer can show up if it's not able to do its job. So you can kind of see how we got from the left to the right here of healthy cells, mutation, mutation, cancer. All right, the bottom half here is when one parent has a mutation in one of these cancer fighting genes, they have a 50-50 chance of passing it to any child that they have. So if a person is born with a mutation that they inherited from a parent, it only takes 1 random mutation that might happen along the way to put that person at risk for cancer. So in essence, I could sum up this whole slide for those of you who got lost by saying, when we're talking about hereditary cancer, it's like being born with 1 hand tied behind your back, trying to fight away cancers. It puts you at a higher risk. Now here's another delineation that's important to know with what's happening with oncology and genetic testing right now. You or your loved one may have had your oncologist say, hey, you know, I want to do a genetic test on your tumor or your cancer to see if we could find out which chemo drug might be a good fit for you. Well, that is a type of genetic testing that doesn't test what you were born with. It doesn't tell us if there's something hereditary going on, but it does tell us which mutations are in your specific cancer cells that might respond appropriately to a certain chemo or another. So that kind of genetic testing is called somatic genetic testing. And I think I've got that word on my next slide. Yep, here we go at the bottom. Somatic mutation. So genetic change that's neither inherited nor passed on to the offspring is called somatic mutations. So I wanted to just put that out there because that's happening more and more in oncology care. As I understand it, oncologists are using somatic genetic testing to help make treatment choices, but that's a different thing than hereditary genetic testing that we've been talking about so far. So just want to point that out.
As a genetic counselor, you're looking at healthy people that might be at increased risk of cancer based on something they inherited from a parent.
Correct.
And we're testing the tumor rather than the person with the somatic mutations.
Yeah, you as the oncologist. Mm-hmm.
Right.
Okay, so you'll see on the left here a whole bunch of letters and numbers. When they named genes, they did not make it simple. They just throw a bunch of letters and numbers at them, and it's my job to keep it all straight. But the point of this slide is that you may have heard people talking about the BRCA genes or the BRCA genes, and those are 2 that you see here at the top. But I wanted to point out that that's only a small part of our knowledge nowadays. We know about a lot more genes that we offer testing for. So if someone in your family said, oh, I had the BRCA gene tested 5 years ago, that's not the most current test that we have to offer. So that's something that you may hear about. Now, here's what many of you are probably thinking about, because you're probably thinking through your family, thinking about Uncle Joe and cousin Jane and these people that that have had cancer, and you might be wondering, well, okay, you're telling me that most cancer is sporadic. A small portion is hereditary. How do we know? Well, the first step is when we look through family histories, we look for certain things. So we look for high numbers of cancer cases. So if we see 3 or more family members with the same cancers or with cancers that run together, that's a concern. If we see people with cancer happening early, remember age is our biggest risk factor for cancer. So if we see younger cancers under age 50, it makes us wonder, could there be something hereditary going on there? Is the reason for that? And if we see a person that has multiple primary cancers, so that means more than one cancer in different parts of the body, not cancer that started in one part and spread to another part, but 2 independent cancers. And then certain types of cancer in and of themselves just tend to be a little more concerning for something hereditary. For example, so if you or someone in your family has had ovarian cancer, pancreatic cancer, male breast cancer, or metastatic prostate cancer, even if there's nobody else in the family with cancer, just having one of those in the family is enough to raise a red flag. And then if we see folks that have lots of colon polyps, having a polyp here or there as we age is not a big concern. But when we have, over 10 or dozens or more polyps, that's a concern to look into.
So there are people that come to you that maybe don't have as many of these factors. And it may be that you don't even think that it's worth the time and trouble and expense to get a test.
Sure.
And
yes.
even if they have all these things and they get the testing, it's a relatively small percentage that come back with the gene.
Yeah. So if you think about, back to that pie chart with the 3 sections in it, if 5 to 10% of all cancers are hereditary, that's pretty much what we expect to see as the percentage of people that would test positive. It's interesting. A lot of people come in, talk to me about their family history, and my job is to run the family history through these filters, so to speak, in my head of what's documented as a concern or maybe not a concern. And a lot of people say, "Oh, surely this has got to be hereditary. Everybody in the family's had cancer." Well, that's not necessarily the case. It's not automatic that you're going to test positive for one of these things just because you have some of these concerns.
Great.
All right. So I just wanted to point out some of the, what does it mean? What do we know if someone tests positive for a hereditary cancer gene? So first of all, it very rarely would we ever say that a genetic result being positive would give someone a 100% chance of having cancer. So simply because you test positive for a hereditary cancer gene does not mean that your chance is 100% to have cancer. And as we talk more, you'll hear about what options there are to reduce these risks. But here's an example. Again, back to those BRCA genes that you probably heard about. Over here, we've got what the average person's risk for ovarian cancer in blue and breast cancer in pink is. Well, a person who has a BRCA mutation, their breast cancer risk jumps to somewhere in the range of 60 to 87%, and their ovarian cancer risk jumps up to 20 to 45%. So it's a significant jump. And the good news is that we have interventions to lower those risks. Here's another one that doesn't get quite as much attention as BRCA, but it's still just as prevalent. So there's just as many hereditary colon cancer families out there as there are hereditary breast cancer. But breast cancer gets a lot of attention, which is fine. But don't think that breast cancer is the only one that can be hereditary. So, for example, here if we look at, there's something called Lynch syndrome, which is a hereditary colon cancer pattern in a family. So you could see that the risk of colon cancer is usually about 5 or 6%, but if somebody has one of these Lynch syndrome genes, it jumps to 60 to 80%. So yeah, so we're talking about risk increases with different genes.
So Lindsay, I'm going to ask this now. I came in through the chat, which I love because there's people
Yeah.
listening and they're actually listening. So I have a lady who had breast cancer and a sister and a mother. And 5 years ago, she tested negative for BRCA.
Uh-huh.
But listening to you, she wonders if she should get a more extensive battery of tests. And,
Sure.
I guess this would be a reasonable time to tell them how
Yeah.
to go about doing that and
Yeah.
contacting people like you.
Mhm. So there's a couple of good points in that question, so I'll try to get to all of them. One, if the person asking the question has never had a cancer, but their relative, I think you mentioned maybe it was a sister and a
Sister, yeah,
mom,
right.
the best person in a family to do genetic testing first is someone who's living, who has
Okay.
had cancer, and even more preferably, the person in the highest living generation. So if the mother or sister is living for that woman, then my advice would be one of those ladies would be the best person to do genetic testing. The second part of that question that needs an answer is, you mentioned, okay, it was 5 years ago when somebody had genetic testing. We do know a lot more. So we would say that we could pick up at least probably 30 to 40%, 30 to 40% more people with hereditary cancer would have a positive result now versus 5 years ago, based on how much more
Just
that
in
we've
5
done.
years. Wow.
Yeah. I think hopefully that answered all the points in that question.
Well,
question.
and eventually just ways that people can get a hold of counselors like yourself.
Yeah. So
We can say that at the end.
yeah, that'll be on my last slide. We'll get that
Okay.
surely, because
Awesome.
I know that's what everybody wants to know too. So, all right. So why would anybody want to know? It's kind of a big, deep question. Some people say, okay, I hear what you're saying that, I could be a person who might benefit from genetic testing, but why would I even want to know if my cancer risk? Why can't I just assume that I have a high chance of cancer and that be good enough? Well, we can be more specific, and it's okay if people don't want to know. First of all, that's a personal choice. That's totally fine. But the reason that some people do want to know is that we can be specific and say, okay, what exactly is going to be your risk? And then what can we do to lower that risk specifically? So this is kind of a broad list of options, but risk reducing surgery. So if we turn up a cancer risk in a body part that's not essential, or that some people say, okay, then I want to have that body part removed, be it ovaries or be it breasts. Some people choose preventive mastectomies, that kind of thing. Medication, there are medications that can lower breast cancer risk and also ovarian cancer risk and other risks as well. Increased surveillance. So this is something that everybody, if you're doing your checkups and getting your annual doctor's visits, there's a plan that says, okay, every woman when they turn 40 needs to have a mammogram. Everyone when they get to be 45 or 50 needs to do a colonoscopy. Well, if you have a hereditary cancer risk, those surveillance recommendations get pushed aside and you get a personalized plan of more frequent and earlier surveillance. So for example, when we find that a woman has a hereditary breast cancer risk, we say, we're going to start screening with breast MRIs in your early 20s, which is above and beyond what the average woman gets to do. So, and then this fourth bullet point was kind of hearkening back to what I mentioned several minutes ago, that sometimes when there's a hereditary cancer found, it guides oncologists as to what chemo could be a good fit. And sometimes it also opens up clinical trials for certain treatments. But you should know.
Well,
go ahead.
Yeah, one of the things that we want to also emphasize is that, genes are not your destiny. Obviously, when you find a gene, you have to do some things and make some decisions, but you can also, and we emphasize this a lot, we can do a lot of good with lifestyle changes. And there's
Absolutely.
evidence-based lifestyle medicine. And we're going to talk about in the spring epigenetics, about how genes may or may not produce their protein that actually implicates them in causing cancer. So there's some things, you're not just sitting there passively. There's some things you can do as well as this increased surveillance.
Yes. And we follow patients every year. So every year, if a person has a genetic hereditary risk, we see them every year and review the plan, because we get this information changes. We might one year say, oh, hey, we had a new large study of people with this gene, and now we think you need to be doing this, and which is new information. So yeah, we don't just tell people, oh, well, there you go, good luck with that. We aggressively follow people as aggressive as they want to be followed. Yeah. Now let me transition into this topic, because I get this question, or this motivation comes up a lot. People tell me, well, I'm not, okay, whatever, maybe I've already had cancer, or I'm not real concerned about myself, but I have 4 kids and I'm a parent. I want to do anything I can to give information to my kids. So great news here, because if we find that someone has a positive hereditary cancer result, the laboratories will do the testing for free for family members. The typical pattern is a 50-50 pattern. So typically, if you test positive, it's like flipping a coin that any of your children would have that same gene. And it's nothing we can control at this point. But the good news is that the whole goal is we don't want any more cancer. And so if we can know that your children or your siblings or other family members are at increased risk, that's a piece of information that can change a family tree that we didn't have a generation ago. So it can be very powerful information. And it's also, the wonderful news is that it's so accessible. It's way more accessible than it ever has been to have this type of genetic testing. Logistically, before I go into the next topic, because I know people are dying to know this answer, probably. Don't you think, Dr. Jagir? Everybody wants to know, what does it cost?
Right.
And
well,
will my insurance
4
cover it?
figures is what I'd estimate.
Well, that's a lot of what people would typically estimate. The great news is that most insurances cover this testing, because insurance companies are getting more and more on board of seeing the benefit of prevention strictly from a dollars and cents standpoint. But also, if insurance doesn't happen to cover it, a lot of the labs that we work with, and again, this testing is done at national labs, not local labs, but we work with these labs, and many people, the max out of pocket most of our patients would ever pay is $250, which is money. But if you're thinking of the other things in medical world, that's a pretty reasonable cost. And again, that's only if insurance doesn't cover it. A lot of times it does.
Now, is that $250 for the family members too?
That would be for the initial person in the family. And if that person tested positive, that's when the free testing can be done for the relatives.
That's really important to know.
Mm-hmm. All right, so let me, I'm gonna see if I can maybe pick up my pace, because I don't want to miss out on any question time. But if you remember back to our pie chart, we had this section over here called familial cancers. So those are the situations where a genetic test turns up negative, which again, it frequently does, but we still have a lot of cancer in the family. So we just don't ignore that cancer. Something caused those cancers in the family. It could be something that's hereditary, but we just can't put our finger on it yet with our knowledge. Could be something in the environment. So a couple of examples of what we would do, and I'm skipping this slide because I basically just said everything on it. Here is an example of what we call a pedigree. So this is what we gather for every patient that we see. This is just our way of categorizing this information in a uniform way. So these are kind of interesting. We give these to all the patients that come in because it's kind of fun. But basically, this tells us the relationships of people in the family. So the arrow would be pointing to the person that we're talking to. And, maybe this person had a brother and a sister and a son. Men are squares, women are circles, if you hadn't figured that out. Mother, father, uncle over here on mom's side, grandparents over here, aunt over there on dad's side, so on and so forth. So that's something that's kind of interesting to people that we look at. But anyway, if people have family history of breast cancer specifically, we do have some statistical models that we use to guide women in those cases to say, hey, your genetic testing was negative, but you still had a sister and a mom with breast cancer. We still need to offer you something above and beyond. So that could be medications or extra screenings with MRI. With ovarian cancer, I know probably some of you guys listening have had either personal experience or family member experience with ovarian cancer, and you probably know that screening for ovarian cancer is not where we want it to be, to say the least. So if a woman has ovarian cancer and her genetic testing is negative, her close female relatives can still have a little bit of an increased risk. And we want people to be aware of that, but screening is still not what we want it to be for that. Similarly, but better screening though for colon cancer, people that have early onset colon cancer in the family or multiple cases, we still want those family members to do early colonoscopies themselves. Pancreatic cancer, not great screening there for people with pancreatic cancer in their family, but we do offer it in a more or less a research type of setting with MRIs and ultrasounds. Let's see. Now, let me kind of get into any of the nuts and bolts of the process of genetic counseling and testing. I think, Dr. Jagir, we've covered some of these topics already.
So one thing, you said November was Family History Awareness Month?
That's right. I think I said that correctly. Family Medical History Awareness Month.
Family Medical History. So as we're sitting around the table on normal years, and maybe we have a Zoom Thanksgiving this year, but instead of talking politics, we can talk family history. And one of the things I'm guilty of, and I think most physicians are guilty of, is that when we see you the first time, we do ask about your family history. And then you can follow with us for 20, 30 years, and we never ask it again. So I would just encourage people to keep track of their family history and recognize that changes, and that's something from the standpoint of genetic counseling, your doctor needs to know.
Mm-hmm. Right, yeah. And I think sometimes bringing up the subject, although it's way less tricky to talk about than politics, right? Sometimes it's still a little bit awkward. Sometimes it can still feel a little bit awkward to ask your family members about their medical history. But my experience has been that people are happy to tell you if you just ask. Nobody or very few people are not going to tell you something. You just have to ask. But if you don't ask, it's never going to come up. And the other thing I like to point out is, unfortunately, lots of people have not so great relationships with their family members. Maybe they don't talk to Sister Betty anymore because of something that happened 20 years ago or whatever. But I can tell you that you need to have good relationships with your family members, because you never know what kind of information is going to be needed to be shared. So yeah. Let's see here what we haven't touched on in these next few pieces of information. So if you think, if you've been thinking as we've been talking here, hey, I think genetic counseling could be something that I would benefit from. Well, what really happens? Well, it's not scary. We simply talk to you. You tell us what you know about your family history. The details that we want to know are what types of cancer people have, where did it start, and how old people were when they were diagnosed. And of course, if anybody in the family has had genetic testing, we want to know that. So we go over that. We talk about benefits, limitations, cost of genetic testing. And, we've touched on these benefits before, but genetic testing gives us a more accurate picture of risk, helps us develop screenings, helps family members. We've covered all that. Here's a couple of really important things to know. So there are some limitations to genetic testing, one of which is something called variants of uncertain significance. So you probably, I'm going to move to this next picture to help explain this. All right, so we have three categories of results here. We've talked a lot about, well, okay, positive results. We have hereditary cancer. We manage that risk, talk to family members. We've talked about negative, which is, well, we didn't really turn up anything, but we still don't ignore what's in the family. But about 20% of the time, we turn up these variants of uncertain significance, or VUSs. What those are changes in the DNA that the laboratory does not yet have enough data on to determine if it's anything to be concerned about. We all have differences in our DNA from person to person. Most of those just make us different and don't increase our cancer risk. But when they find these things that they don't have enough data on yet, they have to put them in this VUS category until they figure them out. 90% of the time when they figure them out, they call them negatives. But rarely, 10% of the time, they figure out that they're positive. They notify us, we notify patients, and we go from there. So that is a limitation. And it's kind of a limitation of a lot of medical tests of various different types that, there's always a gray area sometimes when you do a lot of different kinds of medical tests. So that's important to know. I think we're going to move on here to the next one. Well, genetic testing is a very simple thing to do. It's done simply from a blood test. We can use saliva tests. We like to use blood tests, not that saliva tests are inaccurate, but there's just a little bit more of a chance that they wouldn't get enough DNA from somebody's saliva. These are all sent to specialty laboratories. No local hospital laboratories do this type of testing. It takes 2 to 3 weeks to get results back. In our setting, we contact patients directly, whatever the results are, and talk through what we need to be doing based on the results. We already talked about that last bullet point, number one question, will my insurance pay for this? The answer is oftentimes yes. And in our setting, we are able to, patients can have that answer of will my insurance pay for this before they choose to do the testing. So that's another reassurance. So this is a fun slide. There's a lot of people out there who are kind of armchair genetic counselors, so to speak. They've heard these kind of old wives' tales about genetics and how these things work. So it's kind of fun to debunk some myths. So the first, I hear it a lot. Oh, well, there was all kind of breast cancer on my dad's side, but the breast cancer genes, they don't come through men. Not true. It is just as likely that you can inherit a breast cancer gene from your father as you could from your mother, but it's less likely that your father would have a breast cancer because he's a male and has very little breast tissue to show up for a cancer to show up in. The next one is fun too. Oh, that gene skips generations. Well, not true. Genes or mutations in genes don't skip generations. Where that thought comes from is, if you remember a few slides ago, we talked about how if you have one of these hereditary cancer genes, it doesn't give you a 100% chance of cancer. Let's say maybe it gives you, that particular gene, a 60% risk of cancer. Well, the parent that you inherited that gene from could have been in the 40% that didn't ever get a cancer. So sometimes the cancer can appear to skip generations, but the genes do not. I hear the third one a lot too. Oh, I look just like my sister and she had breast cancer at 20, so surely I'm going to be the same way. No, these genes and these risk factors they travel separately from appearance genes. So that's an interesting one too. We've already debunked the fourth one here. If you're a carrier, there's nothing you can do about it. There's all sorts of things you can do about it. And we've also talked about the next one. If you test negative, there's nothing more you need to do. Well, no, we often still offer high-level screenings. I get the next one a lot, and because a lot of people say, well, I'm worried that if I do this genetic test and I find out that my risk of cancer is increased, that my insurance is going to drop me. That's illegal. So there's legislation called Genetic Information Non-Discrimination Act. It was passed in 2008. It's separate from the Affordable Care Act that makes that illegal. So that's reassuring as well. And we've already talked about the next one. Testing is not too expensive anymore. Insurance usually covers it. The last one, it kind of goes back to that thing of people saying, well, you know, if I've already had cancer, will this really help me? Well, yes, it will, because it can help us determine what other cancer risks you have, as well as for your family members. Can you think of any more that risk, these kind of statements that you hear, Dr. Jagir, sometimes?
No, that we have enough myths in treating oncology patients, so you
Yes.
keep yours.
Okay. All right. Let's change gears. I have a hunch that if I asked anyone watching or listening this to raise your hand if you have done an ancestry genetic test, I'm pretty sure I'd get a lot of hands up, which is fine. That's in the category of what we call direct to consumer testing. So you would be the consumer and you would simply be, you know, saying, yes, I want to pay this company $100 or whatever to tell me what my ancestry is. That's fine. There's no harm in that. I like to file that under the entertainment category rather than the medical information category. So couple of cautions here though. There are some of the companies that offer this ancestry type testing that now offer quote unquote medical genetic testing, and some of that would be cancer risk. So for example, the BRCA 1 and 2 testing that is offered by one of these direct to consumer companies, 23andMe, they test for 3 particular mutations in the BRCA1 and 2 genes, but there's over 1,800 mutations in those genes. So my fear is that there would be people who might do that test, get a negative result for these 3 mutations, and not necessarily pay attention to the details that, oh, well, that was nowhere near a thorough test for those genes. So I really caution people against doing medical genetic testing in a direct to consumer setting, because it can lead to some misinterpretation of results. So yeah, be on the lookout for that. And this is again what I just said in that last slide. Another word to the wise, particularly for our Medicare population. So we've had patients tell us, oh yeah, somebody called me and said that I could do genetic testing for cancer and Medicare would cover it, and I just needed to spit in this tube and send it in. And it was not anything ordered by their physician or by a genetic counselor. It was something that they kind of got almost a scam phone call about. So, you know, I caution people, you know, if you're curious about these things, we're very accessible. There's multiple genetic counseling locations and centers in the upstate. Talk to your doctors. You don't have to assume that you can only do this through someone who is maybe has dubious intentions.
So to that point, I guess it would be state to state that regulates genetic counseling. I mean, you have done a training and gone to school for a long time, and you know more about this than any of the physicians do. And so certified, is that the best we can do, or can a state regulate this better so that we can prevent the consumer from being mistakenly advised by somebody who doesn't know what they're doing?
Yes, South Carolina can do better. That's the short answer. The long answer is that
That's
it
a
is,
shocker to me.
well,
Yeah,
you know, there's a lot of things we could do better on.
right.
True. So in South Carolina, there is not currently a licensure board for genetic counselors. There's a licensure board for physicians. There's a licensure board for cosmetologists. We think that we need a licensure board because we certainly wouldn't want just anyone who watched a YouTube video or read a few articles saying that they were a genetic counselor. This is powerful information that we want people to have a good, trustworthy source to help them work through it. So other states do have licensure boards, and we as a profession that is fairly new, I mean, it's not brand new. There's been genetic counselors for 30, 40 years now, but in the grand scheme of human history, that's not very long. So it takes time and effort to solidify these certifications and licensure processes. So we are certainly hoping that our legislature in South Carolina will move forward on that, so that patients don't have to worry if the person that they're talking to is legitimate. Let's see, I think that kind of wraps up all the formal topics that I had. Those of you who are curious about doing genetic counseling and testing for yourself, at Prisma, the number there is for our clinic. You can certainly talk to your primary care provider. There are genetic counseling clinics at other institutions across the upstate as well. So I think the question you just want to ask is, hey, are you board certified, even though we don't have licensure, but board certified to be a genetic counselor, and can you help me sort through this?
So we did have somebody on the chat, and what if you don't have a family history? She's 64 and adopted. Does she need, or should she seek counseling? I mean, that's probably something you'd get at a cocktail party rather than.
Hey, I get all kind of questions at cocktail parties. I love it.
Once we have cocktail parties again.
Right, whatever those are. That's a wonderful question. And I completely understand the curiosity that you would have if you're adopted, because there's just got to be a lot of, it's just a blank page. You don't know. It is certainly possible that you could have a hereditary mutation and not have any evidence of it because you don't know your family members. So in those cases, if your individual cancer, if you've had a cancer, was at an early age, or if it was one of the cancer types that is a little bit more strongly associated with something hereditary, like I mentioned, ovarian, pancreatic, metastatic prostate. So if it's one of those, then insurance should cover the testing, even if you don't know anything about your family history. But if your cancer in and of itself is not particularly concerning based on the age or the type, then we never stop anyone from doing genetic testing like this if they want to. Unfortunately, they may end up having to pay the $250 out of pocket if their insurance doesn't cover it. But I've had numerous people come to me in that exact situation, and they say, you know what? If insurance doesn't pay for it, I just want to know, and I'm willing to pay the $250 if I have to satisfy their curiosity.
Okay. So I've been in there when you are counseling somebody that's got a gene that comes back with a positive mutation, and you give them a lot of written information that they can use. But there is within our organization, there's instead of sending them back to their primary physician and letting him or her sort it out, we do have a high risk clinic as well. So I think that's a real advantage too, to have somebody that's just focusing on these people that are at high risk because they have an inherited mutation.
Yeah. It can be kind of scary when you find out these kind of results for yourself without knowing who's going to help take care of you for that. Because these things are, some of them can be fairly rare, others are not so rare, but there's, I think we can offer a comfort level to patients, because it's always just good to get right to the source of the information with somebody that can manage it without going to Google it first.
Right. Right. Well, thank you for that great talk and the great information. Those folks that have listened, please share that that this is something that's worthwhile with your friends. And obviously, we've streamed this live, but we'll also record it, and this will show up on the Cancer Survivors Park website. That's cancersurvivorspark.org. And our last lecture about nutrition is on there as well. So we'll keep those coming. We are going to take a break for the holidays, and there will be no monthly cancer prevention and wellness series for December. We'll start back on January 14th, and Dr. John Weems, who's an infectious disease expert, will talk about cancer and infection and what's the connection, and hopefully we'll have him talk about a vaccine for COVID at that time. So I advertise that, and we will advertise that as well. So I want you to have wonderful holidays and make amends with your family if you've got to. And I always finish these up with a quote. So this is a Tibetan proverb, and it goes, "The secret of living well and longer: eat half, walk double, laugh triple, and love without measure." And with that, we'll say good night. Good night.